Hello everyone, and welcome back to my channel. My name is Dr. Stephen Roth, and I'm a board-certified oral and maxillofacial pathologist. Today, I have a very special video that I am extremely excited about. I will be showing you how I approach a biopsy for direct immunofluorescence in an actual real-life patient. Before we get into it, just a few quick disclaimers. First being that all opinions expressed in this video are mine and mine alone and do not represent any organization that may employ me or that I may belong to, and that this video is for educational purposes only and should not serve as medical advice. Should you have any questions or concerns about your oral or systemic health, please see your nearest oral or systemic healthcare provider. An additional word of caution, this video is an actual procedure performed on a real-life patient. If you are squeamish or have difficulty with blood or medical procedures, I recommend turning the video off now. Additionally, I was given full verbal and written consent from the patient to film this procedure and post it on this channel. I would never post a procedure like this without the patient's full understanding and consent. Also, it is highly likely that this video will get demonetized by YouTube. I don't make a ton of money from ad revenue, but every bit helps. So because of this, it would mean the absolute world to me if you gave this video a like, subscribe to the channel if you haven't done so already, and share this video with someone else that may appreciate it as well. Okay, now that what is officially the longest disclaimer I have ever made is done, let's get into the video. Biopsies for direct immunofluorescence are often used in patients with autoimmune conditions where the patient's antibodies or inflammatory markers can be directly visualized in their tissue. In oral pathology, we often use these in vesicullobullous conditions, like those that I describe in my desquamative gingivitis video, which I've linked down below. This patient presented with severe desquamation and ulceration of the entire oral cavity. This presentation to me was very concerning for Pemphigus vulgaris, and that was my working diagnosis at the time that I met the patient. To review Pemphigus, check out the other video that I linked down below as well, where I did a comprehensive review of this condition. It would probably be helpful to watch that video in understanding everything that I say fully. With Pemphigus, it is incredibly important to get a diagnosis. There are a few ways to do this: blood tests, traditional biopsy, and biopsy for direct immunofluorescence, or DIF. I usually do all three to both maximize my odds of getting a diagnosis and minimize the likelihood of insurance denial for rituximab, an infusion medication that works extremely well in this condition. Yes, some insurances actually require 2 positive diagnostic tests before approving this medication. Oftentimes, I will split my biopsy in half, with half going in formalin for traditional processing and half going into Michelle's solution for DIF. You'll see this in this video as well. These biopsies are extremely technique sensitive, and the goal is to obtain peri-lesional tissue. If you obtain lesional tissue, the tissue sample is just an ulcer and is non-diagnostic. If you take tissue too far away, on the other hand, then you may get a false negative. The problem with peri-lesional tissue, especially in Pemphigus, is that it can be super fragile, like tissue paper. In fact, you'll see my first attempt on this patient fall apart during my manipulation. Even though I perform these biopsies with some frequency, rather than editing it out, I included it to highlight the difficulty. The important thing to recognize is that the sample will be inadequate and you must go back for an adequate sample. So with all that being said, let's take a look at my approach together. Okay, so here we can see the patient. I've retracted the lip and you can clearly see the ulceration that's going on. Now I'm gonna pause the video and you can see the ulceration on the lower lip. In patients that have diffuse disease, I like to do places that are easily accessible. So lower lip or anterior cheek. That way I'm not struggling to see what I'm doing or pulling tissue away from one another. The most accessible tissue on the lower lip or buccal mucosa make everything a little bit easier. If those aren't either really present, if there's not a lot of activity in that area, or alternatively too much activity in that area, then I usually go to the ventral tongue next. If that's not good, then you're kind of stuck with either attached tissue, gingiva, or palate, which can be really difficult, or soft palate. But again, I like to go with the lower labial mucosa or the anterior buccal mucosa because it's easy to access, it's easy to see, and it's easy to get your biopsy done. So let's go back to the video here. The first thing that I do with any biopsy is that I like to use a topical anesthetic, a topical benzocaine gel. This will keep the patient comfortable when I do my injection. It's a little bit more difficult in these patients because sometimes that tissue will tear apart. Here we have our anesthesia, direct injection with a typical lidocaine with epinephrine solution that you do with any dental procedure. I find that wiggling the lip helps to distract patients. You'll see that it's already bleeding because the tissue is really very fragile. So to test to make sure the patient's numb, I use my retractor there. I'll pause for a second. So I like to use the periosteal, and I will show them. I'm going to test to make sure you're numb, and I make sure that I've got profound anesthesia before I do anything. The next thing you're going to see me do is place a retraction suture. Now, because this tissue is so fragile, the retraction suture helps to keep everything in place. And what I mean by that is if you use forceps or try to freehand with the scalpel, typically that fragile tissue paper tends to fall apart. If you can get a retraction suture under your tissue with just enough of that connective tissue, it'll help keep everything in place and prevent tearing. I like to use silk suture. The reason being is that gut or resorbable sutures tend to get really sticky. And so a silk suture helps to stay strong and intact when I'm doing my procedure. So let's take a look at how I apply that retraction suture here. So I'm placing it into the lip. I'm getting a piece of perilesional tissue close to, but not directly in that ulcer. And you're gonna see that when I put it through, I'm going to gently move that suture needle through the lip and then have my suture ready. Now, my first pass, as I mentioned, it does fall apart. So you're going to see that just how fragile this tissue is. So when I grab, I go to pull, and then I use my scalpel to try to release the tissue under that retraction. You're gonna see that even with my gentle pulling on that suture, right about here, the tissue starts to rip. Now, I don't throw that tissue away. I did submit that tissue as well. But to me, I wasn't satisfied with the quality of that tissue. But I do have a little lip of tissue next to it that is already kind of cut. So I'm able to kind of lift it up with my forceps here and then just remove it with my scalpel. Here's another attempt to make sure that I get the tissue that I need that's adequate for my sample. So you can see really clearly that I'm getting it under the epithelium with a little bit of connective tissue. You can see again just how fragile this tissue really is. Gentle pulling with that silk suture, and then I release it with my scalpel. You can see that I'm getting a decent chunk, but not too much. And there we go. So I've got connective tissue and the epithelium there. I use silver nitrate to stop bleeding. The nice thing for these patients that it's kind of a blessing and a curse with this ulcerative disease is that a lot of times because they're already in significant pain from ulcerations that they don't even notice the biopsy site postoperatively. But I like silver nitrate. It really helps with tissue healing as well as hemostasis, getting the bleeding to stop. In these patients, sometimes I do place a suture, but because the tissue is so fragile, the sutures don't really help with closure. So I really do find that silver nitrate is best. The next thing that I do, you can see that I am putting it on the piece of that suture paper, and I'm putting it so that the connective tissue is face down, while the epithelium or the surface is face up. So I've got it flat. This will help to make sure that when the tissue fixes, that it stays oriented the way I like it. Here I go with my scalpel to split it in half for formalin, half in Michel's solution for direct immunofluorescence. I don't like to do a lot of sawing motion. I try to do it with one clean break. The reason why is if you saw it, again, more movement can kind of tear that tissue apart. So I try to keep it one clean cut. I use the scissors to separate it, and then I place one in formalin and one in Michel's solution. You cannot do direct immunofluorescence if it's fixed in formalin, so it has to either be frozen right away or placed in Michel's solution. This is the formalin with the white cap. Michel's solution has usually a green cap. Once the tissue is in Michel's solution, it's really important that it is read quickly, usually around 2 or 3 days. Otherwise, you could get an inconclusive result. So it's really important that that result is read out very quickly. But there you have it. That is an actual procedure that I did in a real-life patient to try to get diagnostic tissue for Pemphigus vulgaris. I did succeed, so I was able to get both positive formalin results, positive DIF results, and even a positive blood result for this patient. The patient was put on rituximab, and at my follow-up 3 months later, the patient was doing incredibly well. So this ended up as a happy ending for this patient. There you have it. I hope that you found this video helpful, and if you did, as I mentioned before, please subscribe if you haven't done so already. It is a tremendous help in extending the reach of these videos so more and more patients, providers, and the public have a better understanding of these oral disease processes. A shout out to Dr. Julia Price, my former resident, for her assistance in filming this video. Thanks again for watching, and be well.